Welcome back to the deep dive. Today, we're tackling something pretty heavy, actually. We're doing like a deep morbidity and mortality review, focusing on a challenge every cartilage surgeon dreads, the fail to repair.
Mm-hmm.
We've got a stack of studies here, and honestly, it forces us to get really systematic. We're moving past the excitement of the primary surgery
Right.
and diving headfirst into the gritty reality of revision management.
It really is a critical point in our field, isn't it? Because, like you said, we put so much energy into these amazing new biologics, these advanced techniques.
Yeah, the cutting edge stuff.
But the clinical reality can be, well, quite sobering. Our sources, the papers we're looking at today, they consistently show that the clinical failure rate for articular cartilage restoration, doesn't matter if it's microfracture, ACI, osteochondral grafts, it often hits around 25%.
25%.
Yeah.
1 in 4.
1 in 4. Across multiple series, that number keeps popping up. Refs 3, 12, 14, 19 all point towards this. That means a quarter of the patients we treat for these focal defects, they're going to end up back in our clinic with symptoms.
Wow.
So yeah, we have a professional obligation, really, to figure out a solid, systematic way to handle these cases, an algorithm, if you will.
Exactly.
Yeah.
So our mission today basically is to put on our detective hats.
Surgical detectives. I like it.
We're not just looking at that hole in the cartilage again. We need to conduct a proper forensic investigation, figure out why the first repair actually failed. Because just going in and trying another cartilage procedure without fixing whatever caused the first one to fail,
Yeah.
well, like you said, that's just setting everyone up for another disappointment. It's malpractice with extra steps, almost.
It really is. You have to analyze the failure mechanisms to sort of reverse engineer success for the revision.
It makes me think of like trying to patch a flat tire.
Right.
You can patch the hole, the focal defect, but the knee isn't just a tire, is it? It's this incredibly optimized, complex mechanical system.
Precisely. And if that initial repair failed, it probably wasn't just a simple tear or wearing out. Often it's a deeper foundational structural issue.
Like the analogy you used earlier, the leaky roof.
Exactly, the leaky roof analogy. You might see the water dripping. That's the graft defect, the symptoms, and you're focused on patching that roof leak. But you could be completely wasting your time and resources if the entire house foundation is sinking.
Because of, say, severe malalignment.
Or meniscal loss, or chronic instability. Things that create a hostile environment for any repair. Until you fix that underlying frame, no advanced material, no fancy biologic graft is going to hold up long term. It's just not going to work.
So for you, the listener, whether you're a clinician prepping for one of these tough revision cases, or maybe even someone navigating a complex diagnosis yourself, understanding why these things fail is absolutely key.
It really is.
It doesn't just determine if the second, often much harder, revision surgery will work. It actually helps us get better at selecting patients and managing expectations for the first surgery. It makes our primary outcomes better too. It's all connected, isn't it?
Completely interconnected. Understanding failure informs success.
Okay, so let's start at the beginning. How do we even define failure in this context? It sounds obvious, but maybe it's not.
That's a great place to start because it's often misunderstood. Surgeons, we sometimes fall into the trap of defining failure just by looking at an MRI. Oh, the graft fill looks pretty good on the scan.
Right, looks okay to me.
Exactly. But clinical failure is much broader. It's really about the patient's experience. Are they still having persistent pain? Are they fundamentally unable to get back to the activities or sports they wanted to do?
That's the big one, isn't it? The return to activity.
It is. Or are we seeing clear, undeniable evidence that the joint is progressing towards degenerative disease on x-rays despite the repair? That's failure too.
So if a patient comes back and says, look, doc, maybe my knee doesn't hurt much when I'm just sitting around, but I still absolutely cannot run, I can't play basketball, even if a second look scope shows the graft looks, reasonably intact.
That's a functional failure.
We have to call that a failure, right?
Yeah.
Because the index procedure didn't meet the patient's goals. Failure isn't just a visible crater, it's the absence of function.
Precisely. And what makes it tricky, sometimes quite deceptive, is that these symptoms, the pain, the lack of function, they can persist even when the graft itself doesn't look obviously deteriorated on imaging.
So what does that point to?
It forces us, as those surgical detectives, to look beyond just the graft site. We have to critically evaluate the entire joint. Is there subtle compartmental overload? Is there underlying instability we missed? Are there other comorbidities contributing? This rigorous diagnostic approach, looking beyond the obvious, is really step one.
Okay, so when we're trying to figure out the why, the timeline seems really important. You mentioned categorizing failures as early versus late.
Yes, the timing of when the symptoms start or restart is probably the single most important clue we get from the patient's history. It helps us narrow down the likely causes.
So tell us about early failure. What does that usually signal?
Right. Early failure. This is when symptoms come on fast, usually within the first few months, maybe up to a year after the surgery. When it happens that quickly, it almost always points back to something that happened either in the operating room or in that immediate post-op period.
Like a technical mistake.
Yeah, unfortunately, the most glaring cause can be a significant technical error. I mean, our sources show examples like in figure 33.1. There's a case of an osteochondritis dissecans, an OCD lesion, treated with a screw. But the screw was left prominent.
No.
And it basically acted like a cheese grater on the opposing tibial cartilage surface every time the knee bent. That's just a pure, immediate mechanical catastrophe, a clear technical failure by the surgeon.
Ouch. Okay, so technical error is one possibility for early failure. What else?
Well, even if the surgery was technically perfect, you can still have early failure due to immediate biological issues. Maybe the graft just didn't get that initial blood supply, failed to incorporate. That can happen.
And then there's the patient factor.
Ah, yes, patient noncompliance. This one is particularly frustrating for surgeons. We spend hours planning these meticulous rehab protocols, like 6 weeks of strict non-weight bearing to let that delicate graft integrate.
Yeah, all those instructions.
And if the patient decides, I feel pretty good, and starts running on it after 10 days, well, that massive, immediate premature load just destroys the scaffold. It guarantees failure.
Oh, so ignoring the PT rules. Got it.
And of course, an acute, significant trauma soon after surgery, like a fall or a direct blow, that can also cause an early rapid failure.
Okay, so that's early failure, quick onset, usually linked to the surgery or immediate aftermath. What about the other side of the coin? Late failure.
Late failures are often more insidious. These are the patients who actually did really well initially. Maybe for 2, 3, even 4 years, they were happy, active.
Feeling like it was a success.
Exactly. And then gradually, slowly, symptoms start to creep back in. Pain, swelling, decreased function. This slow decline tells a very different story than the rapid early failure.
What's the story it's telling?
It suggests a few possibilities. Maybe the graft itself, while it integrated initially, just failed to fully mature into durable tissue. Or, perhaps more commonly, it points to a gradual, relentless progression of some underlying problem that we either missed or underestimated during the initial workup.
Like that subtle malalignment you mentioned.
Precisely. Maybe the patient had a slight varus alignment, just a few degrees. The graft went in, healed okay, but every single step they took year after year concentrated stress onto that medial compartment, onto the repair site.
Though the graft was just constantly overloaded.
Constantly fighting an uphill battle in a hostile mechanical environment. It survived the initial healing phase, but it was subjected to forces it was never biologically designed to withstand long-term in that non-ideal alignment. That's a classic late failure mechanism, the progression of additional untreated pathology.
And that could be alignment or maybe subtle instability that wasn't addressed.
Or even something like a failed meniscus root repair that gradually leads to increased compartmental load over time. The initial construct, the graft, eventually just breaks down years later because the foundation wasn't stable.
So the big takeaway here is when we see a late failure, we shouldn't just shrug and say, oh, the biology wore out.
No, absolutely not. We should strongly suspect that the hostile mechanical environment finally won the war against the repair.
Which means for any revision case, the immediate crystal clear message is, we cannot just focus on patching the hole again. We must identify and, more importantly, address those underlying reasons for the initial failure, the instability, the malalignment, the meniscal deficiency. That's the unaddressed foundation that has to be fixed first.
That's the core principle of successful revision surgery. Fix the environment first.
Okay, so if we're being good surgical detectives, we need to know the usual suspects, right? Each type of primary cartilage surgery probably fails in its own characteristic way.
Exactly. To be effective, we need to be fluent in the specific vulnerabilities of the index procedure. Each technique, microfracture, ACI, OA-TOCA, it has a unique failure signature, and there are specific factors that predict failure for each one. Knowing these helps us trace back the cause.
All right, let's start with the one we probably see failing most often.
Yeah.
Failure following prior microfracture or marrow stimulation. We know the whole idea here is to punch holes in the bone, let marrow seep out, form a clot. But the clot heals with fibrocartilage, not the good stuff, hyaline cartilage.
And that's the crux of the issue. Fibrocartilage simply lacks the mechanical durability, the resilience of native hyaline cartilage, especially in a high-demand joint like the knee.
And the clinical data backs that up.
Oh, strongly. The clinical failure rates after microfracture are, frankly, quite high. You're looking at anywhere from 11% to 23% failure within just 5 years.
That's already pretty significant.
It is. But the long-term picture is even worse for certain groups. One study, reference 9, showed failure rates climbing up to a staggering 38% at 10 years.
38%. Almost 4 out of 10 patients failing by 10 years.
Yes, and if you look at figure 33.2 in our materials, that's a classic example. It shows a failed microfracture of an OCD lesion on the medial femoral condyle, now requiring a big osteochondral allograft to fix it. That's the typical endpoint in the mechanical failure of that weaker fibrocartilage under years of load.
Wow. A 38% failure rate at 10 years for something we offer active people. That really makes you question its role, doesn't it? It sounds more like a temporary fix, maybe buying time for some low-demand patients, rather than a definitive solution for an active knee.
I think that's a fair assessment in many cases. It begs the question, who is most likely to fall into that 38%? What predicts this rapid decay?
Yeah, what are the risk factors?
Mithyfer and colleagues did some key work here, identifying patient-related risk factors, Ref 18. These factors basically scream biological disadvantage for microfracture. The big three are elevated body mass index, specifically a BMI over 30.
Okay, obesity.
Age greater than 45 years.
Older patients.
And somewhat paradoxically, patients who come in with very high preoperative activity scores.
Wait, high activity is a risk factor for failure. That seems counterintuitive.
It does, but think about it. If you're older, heavier, and you're trying to maintain a really high activity level, you're putting immense repetitive stress on that fragile fibrocartilage patch.
Ah, okay. So the combination is toxic. Older biology, more weight, and higher demands equals failure.
Exactly. The biological engine, the healing capacity, just can't produce repair tissue strong enough to withstand those forces long term. The sheer amount of cyclic loading from a high BMI, coupled with potentially diminished chondrocyte function in older patients, it sets a fibrocartilage up for failure.
Makes sense.
Now, Goyle and others, Ref 7, did find some satisfactory outcomes, but primarily in younger patients with lower activity levels. For the active, middle-aged, or overweight patient, the risk profile for microfracture failing as a definitive fix is just too high, in my opinion.
Okay, patient factors are clear. What about the lesion itself? Does the type of hole matter?
Absolutely. Lesion-related factors are just as critical. First, how long were the symptoms present before surgery? If someone had pain for longer than 12 months,
A year or more.
that suggests a chronically inflamed, stressed joint environment. That's a poor foundation for any cartilage repair, let alone one relying on fibrocartilage. And then, of course, size matters.
Bigger lesions are worse.
Definitely. Lesions larger than about 2 square centimeters, and especially those exceeding 4 square centimeters, are notoriously difficult for microfracture. The procedure's effectiveness just drops off exponentially as the defect gets bigger. The evidence really suggests we should be using a more robust structural solution for those larger holes right from the start.
Okay, that's a clear picture for microfracture. Let's move on to the more sophisticated approach. Autologous chondrocyte implantation, ACI. This is where we actually take the patient's own cartilage cells, grow them in a lab, and reimplant them, hoping for real hyaline cartilage.
The goal is true regeneration, yes. It's a 2-stage process, biologically more complex.
But even with this advanced biology, the failure rates are still, well, they're not zero.
No, unfortunately not. They remain stubbornly high, actually. The literature, Refs 3, 14, 19, consistently shows failure rates clustering between 19% and 23% at 5 years for ACI.
Still around 1 in 5 failing.
Still significant. And figure 33.3 gives us a good visual. It shows a failed ACI right at that tricky junction between the medial femoral condyle and the trochlea, a common spot for issues.
So why does ACI fail? Are the risk factors similar to microfracture?
Some are, yes. Patient factors often mirror what we see with microfracture. Increased BMI is again a problem, as is a higher physical activity level, Refs 2, 13. Fundamentally, if the patient is overloading the graft, especially during the long maturation phase, it doesn't matter if it's fibrocartilage or lab-grown hyaline-like cartilage, too much force too soon is bad.
But ACI seems to have a couple of unique predictors that sound really important, especially when we're thinking about revision surgery.
They are indeed critical clues for the detective. First, several studies, Ref 1720, have identified female gender as being associated with increased ACI failure rates.
Female gender. Why would that be?
The exact biological reason is still being investigated. It might relate to hormonal influences on cartilage health or perhaps common biomechanical differences like alignment patterns, but the association keeps showing up in the data.
Interesting. And the second unique factor?
This one is perhaps the most critical for planning a revision: a history of prior surgery on the knee, especially a prior failed microfracture.
Okay, let's pause there. Why is having had a microfracture before so bad for a subsequent ACI?
It comes back to the compromised substrate, the foundation again. Microfracture doesn't leave behind healthy bone. It leaves behind a bed of often poorly integrated, mechanically inferior fibrocartilage.
Right, the scar tissue.
Exactly. So when we come along later and try to implant these healthy lab-grown chondrocytes with ACI, they're not trying to stick to pristine, healthy subchondral bone. They're trying to integrate into this scarred, biologically suboptimal surface.
What makes it harder for them to take hold and mature properly?
Much harder. The data from Minus et al., Ref 17, is really stark here. They found a 26% failure rate for ACI when it was done after a failed marrow stimulation,
Okay.
compared to only an 8% failure rate when ACI was the primary procedure.
Wow, a threefold increase in failure risk just because of the prior microfracture.
It's a massive difference, and it should absolutely dictate our approach. It tells us that if a microfracture has already failed in that spot, doing an ACI next means the graft is biologically disadvantaged right from the start. Maybe we need to consider a different, more structural solution in that scenario.
That's incredibly powerful data for counseling patients, isn't it?
Yeah.
We also need to think about technical failures specific to ACI, like the graft growing too much or peeling off.
Yes, biologic failure within ACI can manifest in a couple of ways. Graft hypertrophy is one that's where the implanted cartilage grows too thick, overgrows the boundaries of the original defect, and starts causing painful mechanical impingement, like a speed bump.
Ouch.
The opposite problem is delamination, where the graft actually peels away, shears off from the underlying bone it was supposed to integrate with.
Are there technical things that influence those outcomes?
There are, and one fascinating technical detail highlighted in our sources, Ref 6, relates to how the cells are contained. The older technique used a patch of periosteum, the lining of the bone sewn over the defect to hold the cells in.
Right, the periosteal patch ACI.
That technique was found to have a significantly higher risk of reoperation, specifically because of graft hypertrophy. The newer techniques mostly use a collagen membrane, a cellular membrane, instead of periosteum.
And that's better.
It seems to be. Using the membrane has largely reduced that specific problem of graft hypertrophy. So knowing which type of ACI was done initially can be another clue.
Good point. Okay, finally, let's talk about the most structural approach. Osteochondral autograft, or allograft transplantation, OA-TOC. This is where we're actually transplanting a plug of bone and cartilage together. Autograft means from the patient themselves, allograft from a donor.
Correct. We're bringing in a complete osteochondral unit, hoping the bony part will provide immediate stability and integrate with the host bone.
Since this is more structural, are the failure predictors different? Are things like BMI or activity level less important here?
The preliminary evidence, Refs 15, 21, suggests that OCA and OAT failure might be less driven by those patient demographic factors. Yes, younger age generally still leads to better outcomes, like with most things in orthopedics, but other factors like BMI, gender, or even a history of prior surgery don't seem to be as strongly predictive of failure here compared to how they impact microfracture or ACI.
Interesting. So if the patient's biology or demographics aren't the main drivers of failure for OA-TOPO, what is?
It really swings the focus squarely onto the surgeon. The technical execution becomes paramount.
The technical imperative, as you called it.
Exactly. We are transplanting this critical bone cartilage unit, and the margin for error is incredibly small. Failure often boils down to violating one of 3 cardinal rules during the surgery.
Okay, what are the rules?
Rule number 1, recipient site preparation. The hole you make to receive the graft must be completely filled by the graft. Any gaps left around or underneath the plug can lead to cyst formation in the subchondral bone later on. Those cysts act like weak point stress risers that can cause mechanical failure down the line.
So meticulous fit is key. Rule number 2.
Minimal force during impaction. When you're putting the plug into the hole, you have to be gentle. If you hammer it into aggressively,
You can damage the cartilage.
you can literally kill the chondrocytes, the living cartilage cells, on the surface of the plug through blunt trauma. So you end up transplanting dead cartilage, which obviously isn't going to work well. Careful impaction is crucial.
Okay. And rule number 3. This sounds like the big one, the speed bump rule.
Yes, the speed
Yeah.
bump rule. This one is absolutely non-negotiable for Oatoka. The transplanted plug cannot be left proud, meaning higher than the surrounding native cartilage by more than 1 millimeter. Ideally, it should be perfectly flush or even slightly recessed, like 0.5 millimeters below the surface.
Why is being even a little bit high so bad?
Because even a tiny height difference, say 1.5 or 2 millimeters proud, dramatically concentrates all the joint contact pressures onto that small elevated area. Refs 2 and 16 show this clearly. Imagine walking or squatting every single time the joint moves. That little speed bump takes a massive, inappropriate hit.
It just gets hammered.
Constantly hammered. It leads to overload, breakdown of the plug itself, damage to the opposing cartilage surface. It basically guarantees an early mechanical failure due to this excessive localized stress. Getting the height perfect is arguably the most critical technical step.
Wow, that puts enormous pressure on the surgeon's hands during the procedure. Precision is everything.
It truly is for Oatoka.
Okay, before we move on from the procedures, let's just quickly reiterate the size guidelines. If we're dealing with those really big lesions, say bigger than 4 square centimeters.
Right. For those large defects, the evidence base, like Ref 10, generally supports using either ACI or a large bulk osteochondral allograft, OCA, over trying to do microfracture or patch it together with multiple small OAT plugs, mosaicplasty. The structural integrity needed for large defects usually requires a more substantial solution. Knowing the size of the original lesion is critical to figuring out if the right index procedure was chosen in the first place.
Another key piece of detective work. Okay, this is great background on how things fail. Next, let's talk about how we figure this out when the patient is sitting in front of us.
All right, so the patient with the painful knee after prior cartilage surgery walks into your clinic. Now we shift into full detective mode. We need to gather every single piece of evidence systematically, and that process always starts with the history.
Absolutely. We have to become history-taking fanatics here. First step,
Mhm.
get your hands on all the previous records, especially the operative notes and any imaging from the index surgery.
Crucial. It's not enough for the patient to say, oh, I had ACI. We need to know which type of ACI was it. Was it matrix-based, or did they use a periosteel patch? What size was the lesion they treated? Were there other lesions noted or treated at the same time? These details matter.
And beyond the operative details, the rehab story is gold, right?
Pure gold. We need specifics about the postoperative rehabilitation. Was the patient really non-weight bearing for the prescribed time? Did they actually use their CPM machine diligently? Or did they push physical therapy too hard, too fast against advice?
Trying to get back too quickly.
Exactly. And maybe the most telling piece of the history. What was the exact course of their symptoms after the surgery? Did the pain come back immediately when they started bearing full weight? That might suggest an early technical problem or an immediate failure of the graft to integrate. Versus, did they have a honeymoon period? A good year, 2 years, maybe more, where things felt great, and then the pain slowly, insidiously crept back. That points more towards a late failure, maybe due to that underlying mechanical overload or the progression of some uncorrected issue like malalignment or instability finally taking its toll.
The timeline tells this story. Okay, let's talk about the symptoms themselves. Patients usually come in complaining about pain, maybe swelling, mechanical stuff like catching or locking, or feeling unstable. How do we differentiate?
Symptom differentiation is key. Let's take pain. If the defect was on a femoral condyle, the pain is typically very localized to that side's joint line, the medial or lateral side, and it's usually much worse with weight-bearing activities impact.
Okay, straightforward enough. But how do you tell that apart from, say, meniscus pain, especially if they've had meniscus surgery before?
That can be tricky, especially with prior meniscectomy. Meniscal pain is also often felt at the joint line, but sometimes it's perceived a bit more posteriorly. The bigger clue, though, is the history. If you know they're missing a significant chunk of meniscus, that knee is inherently less stable and has lost shock absorption. Even if the cartilage graft itself was perfect, the underlying meniscal deficiency could be causing persistent overload in that compartment, leading to the graft's failure or ongoing symptoms.
So the missing meniscus itself becomes a major comorbidity driving the failure.
Absolutely, you have to account for it. Now, the patellofemoral joint, the kneecap area, it gives its own unique clues.
What should we listen for there?
If the patient complains primarily of anterior knee pain, maybe with clicking or grinding, crepitus, and crucially, if the pain is worst with activities that put high pressure on the kneecap, think squatting, lunging, going up and down stairs.
Loading the knee inflection.
Exactly. That immediately points your investigation towards a potential problem with a trochlear femoral groove or patellar kneecap lesion. It tells you to look very closely at the PF alignment and specifically measure that TT-TG distance we'll talk about with imaging.
Got it. Okay, history done. Next up is the physical examination. What are we looking for when the patient is in the room?
We start just by observing. Watch them walk. Are they limping? That's called antalgia, limping due to pain. Look at their static alignment when standing obvious varus, bow-legged, or valgus, knock-kneed.
And the dynamic assessment.
This is critical. Watch their gait carefully for a dynamic varus or valgus thrust. This is where the knee visibly shifts inwards or outwards with each step during the stance phase.
That sounds bad.
It's a smoking gun. That thrust is basically proof of underlying ligamentous insufficiency, meaning the knee isn't stable. If you see a thrust, any cartilage graft you put in that compartment is already fighting a losing battle because the whole compartment is unstable under load.
So thrust equals probable instability. What else are you looking for in observation?
We also look for and measure quadriceps atrophy. A visibly smaller thigh muscle on the affected side is a clear sign of chronic disuse, pain inhibition, protective guarding. It tells you this problem has been going on for a while. And of course, check for any obvious joint swelling and effusion.
So the thrust is the smoking gun for instability, and the atrophy is like the diary entry of chronic pain.
That's a great way to put it. Then we move to palpation, carefully feeling around the knee. Is the tenderness directly over where we think the failed graft is? Or is it actually coming from somewhere else nearby? Maybe the meniscus rim again, or the pes anserine tendons on the inner side, or the facets of the patellofemoral joint. Pinpointing the tenderness is important.
And the most critical part of the exam and revision.
It's the thorough assessment of all the associated pathology. We keep coming back to this, but it's vital.
The foundation assessment again.
Exactly. Persistent instability, uncorrected malalignment, or that residual meniscal deficiency. These are the three horsemen of the apocalypse for cartilage repairs. They are the most common reasons for premature failure.
So we have to check everything.
Everything, meticulously. That means a routine, comprehensive ligament exam, ACL, PCL, MCL, LCL, and don't forget the posterolatical corner structures. You absolutely cannot plan a revision myological repair without confirming you have a stable, non-shifting mechanical environment. If there's any hint of instability, even subtle, that needs to be addressed, often first.
Okay, history and physical exam give us a lot of clues. Now let's turn to imaging our non-invasive forensic tools. What are the absolute must-have x-rays?
Standard radiographs are the baseline, non-negotiable. You need bilateral knees for comparison. Minimum 3 views. An AP weight-bearing view, the weight-bearing part is crucial to assess true joint space narrowing and static alignment. Then a 45-degree flexion lateral view.
Why 45 degrees specific?
That angle optimally profiles the posterior aspect of the femoral condyles and the trochlear groove, common sites for lesions. And finally, an axial view, like a merchant view, to look directly at the patellofemoral joint space and tracking.
And the big one for biomechanics, the alignment check.
Yes, the full-length alignment X-ray, also called a long leg cassette or hip-to-ankle view. You can see an example in figure 33.4. This is non-negotiable. It's the only way to accurately calculate the true mechanical axis of the leg.
To see if they're varus or valgus.
Precisely. We need to know exactly where that load-bearing line passes through the knee, medial, central, or lateral. If we miss significant varus or valgus malalignment on this view, our entire revision strategy could be fundamentally flawed from the start. We absolutely have to measure that hip-knee-ankle angle.
Okay, x-rays are essential. What about CT scans? We usually think of MRI for cartilage. When would we use CT?
CT scans have a more specialized role, primarily for assessing bony anatomy in detail. Their main utility in this context is for evaluating the patellofemoral joint, specifically for measuring the tibial tubercle trochlear groove distance, the TTTG. Refs 1 and 22 discuss this.
TTG, what does that tell us?
It's measured on axial CT slices, and it quantifies how far laterally the tibial tubercle, where the patellar tendon attaches, sits relative to the trochlear groove, the track the patella runs in. A large TTTG distance, typically cited clinically as over 15 or maybe 20 millimeters, indicates a strong lateral pull on the patella, suggesting significant maltracking.
And why is that critical?
Because if you have severe lateral maltracking causing patellofemoral chondrosis or the failure of a previous trochlear graft, you likely need to perform a tibial tubercle osteotomy, TTO, basically moving the tendon attachment medially to correct the tracking and offload that damaged area. The TTTG measurement from the CT scan is indispensable for making that decision.
Got it. CT for PF alignment, TTTG. But the MRI is still king for looking at the graft and soft tissues, right?
MRI remains our workhorse, absolutely. It gives us the detailed, granular information we need for revision planning. It can map out the size and depth of the lesion, or what's left of it. Critically, it gives us a window into the health of the subchondral bone underneath the cartilage.
What are we looking for in the bone?
We're hunting for signal changes, specifically high signal on fluid-sensitive sequences, which indicates bone marrow edema or swelling. This edema is a huge red flag in the revision setting.
Why is edema so bad?
Because it signifies active stress or failure within the bone itself. It could be due to overload, microfracture, poor blood supply, cyst formation, or non-integration of a previous graft. Seeing that edema tells us the problem isn't just on the surface anymore. The underlying bony foundation is compromised.
So it changes the treatment plan.
Dramatically. MRI also confirms or rules out associated problems, ligament tears, meniscus tears we might have suspected on exam. But specifically for the failed repair site, we're looking for signs like persistent edema, maybe fissuring or cracks within the graft material, or abnormal signal intensity where it meets the bone. Figure 33.5 is a perfect example.
What does that show?
It shows sagittal and axial MRI views months after an OCA, an osteochondral allograft. You can see these bright high signal areas in the bone graft and the surrounding host bone. That's significant subchondral edema, clearly indicating that the graft is symptomatic and failing, likely due to issues at the bony level, maybe poor incorporation or ongoing stress.
So edema on MRI means the scaffolding is failing, not just the surface cartilage.
That's exactly right. It signifies active failure at the bone level and strongly pushes us away from just doing another surface-only procedure like ACI. It suggests we need a solution that addresses the bone, like another OCA.
Okay, last diagnostic tool, diagnostic arthroscopy. When do we actually need to put a camera in the knee just to look around before deciding on the big revision?
We generally reserve a diagnostic arthroscopy for those cases where there's still significant uncertainty after the history exam and all the imaging. Maybe the exact morphology or location of the failed graft is unclear. Maybe the MRI is equivocal about a meniscus tear or the integrity of some prior fixation hardware that could be causing symptoms.
So when you just need to see it directly.
Exactly.
Yeah.
It allows for a definitive, real-time, magnified assessment of the lesion itself, the quality of the surrounding cartilage, and any other contributing factors inside the joint. It can be the final piece of the puzzle that confirms our revision plan, especially regarding the type of graft needed. All right, we've done our detective work, we've gathered history, done the exam, analyzed the imaging. We think we know why the first repair failed, and we've identified all the associated problems, the instability, the malalignment, the meniscal loss. Now, finally, we get to talk about treatment.
The action plan.
The action plan. But before we even think about which type of cartilage graft to put in, the absolute #1 overarching goal is offloading.
Offloading, meaning taking stress off the damaged area.
Precisely. We must neutralize that hostile mechanical environment we identified. If the compartment is overloaded due to alignment, we fix the alignment. If it's overloaded due to instability, we fix the instability. If it's overloaded due to meniscal loss, we consider replacing the meniscus.
So this means using those realignment procedures we talked about. High tibial osteotomy, HTO for varus knees, distal femoral osteotomy, DFO for valgus knees, or the tibial cubical osteotomy, TTO for patellofemoral problems.
Correct. Those are our main tools for correcting malalignment. And for significant meniscal loss, particularly in younger, active patients, we might consider a meniscal allograft transplantation to restore that cushioning and stability. Offloading is paramount.
Is there a specific target when we do these osteotomies? How much do we correct the alignment?
There's nuance there, and it depends on the state of the joint. If the patient has clear malignment, let's say varus, but the cartilage in that medial compartment, aside from the focal defect we're revising, is actually pretty healthy. No significant background arthritis. Then our goal is to correct the mechanical axis precisely back to neutral. We want the load passing right through the center of the knee, distributing forces evenly.
But what if that compartment already has some wear and tear, some early arthritic changes?
That changes the strategy. If there are already degenerative changes present in the diseased, overloaded compartment, we don't just aim for neutral, we actually want to slightly overcorrect beyond neutral.
Overcorrect, meaning make them a bit knock-kneed if they were bow-legged.
Exactly. For a varus knee with medial compartment arthritis, we'd perform an HTO aiming for maybe 3 to 5 degrees of valgus alignment. This deliberately shifts the main load-bearing axis completely away from the damaged medial side and onto the healthier lateral compartment.
That sounds aggressive, but it makes sense if you want to protect the repair.
It's all about maximizing the longevity of both the joint and whatever cartilage graft we subsequently put in. That slight overcorrection provides the best possible mechanical environment for healing and long-term survival in an already somewhat compromised compartment.
Okay, makes sense. Now, often these patients need multiple things fixed, right? Like maybe they need an HTO and a meniscus transplant and the cartilage graft. Doing all that at once sounds like a massive surgery.
It can be, and that's where the concept of staging procedures becomes really important. Trying to do everything simultaneously dramatically increases operative time, blood loss, surgical complexity, and potentially the risk of complications and a tougher recovery.
So how do we decide the order? What gets done first?
The staging priority is usually dictated by the patient's primary functional deficit or main complaint. If the biggest problem is persistent instability, maybe they have a blown ACL or PCL that was missed or failed, then stabilizing the knee with ligament reconstruction often takes priority. You can't put a graft into a knee that's sliding around.
Right. What if the main issue is pain from the overload?
If the chief complaint is pain clearly related to mechanical overload from malalignment or meniscal loss, then the unloading procedure, the osteotomy or the meniscus transplant, often gets done first, sometimes combined with the cartilage procedure in the same setting, if feasible, or sometimes staged.
And you mentioned staging can be useful in older or less active patients.
Yes, staging offers a really valuable opportunity, almost a test run, in certain patients. For someone older, maybe less active, who needs, say, an HTO for alignment and also has a cartilage defect, we might elect to only do the HTO first.
Just the alignment correction.
Just the realignment. Then we wait maybe 6 months, let them rehab from the osteotomy and see how they do clinically. If correcting the alignment alone provides enough pain relief and functional improvement for their needs,
Then maybe they don't even need the big cartilage procedure later.
exactly. We might successfully avoid the need for the second, more complex cartilage restoration surgery altogether. It's a way to potentially achieve the patient's goals with less surgical morbidity.
Smart. But there's a limit, right? When is cartilage restoration just not an option anymore?
That's the critical contraindication we always have to look for. If that initial focal lesion, the one we might have treated years ago, has now progressed to diffuse, widespread, end-stage arthritis involving the entire compartment or multiple compartments.
Bone on bone everywhere.
Bone on bone. Then, unfortunately, trying to patch one spot with a cartilage graft is futile. Cartilage restoration is no longer a viable option, and the conversation has to shift towards joint replacement surgery, like a partial or total knee arthroplasty. We have to recognize when salvage is no longer possible.
Okay, so assuming restoration is still on the table, and we've addressed the offloading and staging, let's get into the nitty-gritty. The revision algorithm based on what we saw in the MRI, especially that subchondral bone signal.
Right. The state of the subchondral bone is the major decision point. Let's start with the scenario where the MRI shows no significant subchondral edema. We think of this as primarily a surface failure. Maybe the original graft is delaminated or got some superficial cracks or wear. Figure 33.6 illustrates this kind of surface-level issue.
Okay, surface failure, no deep bone problems. What are the options?
For small lesions in this category, say around 1 square centimeter, we might still consider an osteochondral autograft transplantation, OAT, using plugs from the patient's own knee. We know OAT has limitations, but it offers immediate structural stability. However, we generally avoid OAT in the patellofemoral joint during revisions. It's just too technically difficult to match the curvature well.
What about slightly bigger surface failures, say 2-3 centimeters?
For that intermediate size, 2 to 3 square centimeters, with no bone edema, a revision ACI could be considered. We'd still have that conversation about the reduced success rates if there was prior microfracture, but it's an option on the table.
But you mentioned earlier that osteochondral procedures, like OCA or OAT, are often preferred in the revision setting, even for surface failures. Why is that?
It often comes down to predictability and recovery time in the revision context. ACI requires that long period, months, of protected non-weight bearing for the cells to mature and fill the defect. Osteochondral grafts, whether auto or allo, provide an immediate, stable articular surface. Instant structure. Assuming we've corrected the mechanical environment, that offloading part. OAT or OCA often offers a more predictable and potentially faster path back to function for the patient, especially when we're dealing with a potentially compromised biological bed left over from the previous failed surgery. There's just less biological uncertainty.
Okay, that makes sense. Now, the game changes completely when we see that subchondral edema on the MRI, right? The high signal indicating bony involvement.
Completely changes the game. That bright signal tells us the underlying bone itself is actively stressed, unhealthy, or failing. It could be due to stress fracture, poor blood supply, cyst formation, whatever the cause. The foundation is shaky.
So what's the go-to procedure then?
If we have a lesion that's 2 square centimeters or larger, and it has that associated subchondral edema, our strong preference shifts decisively towards using an osteochondral allograft, OCA. Figure 33.7 shows a great example of where OCA is needed.
Why allograft specifically?
Because with OCA, we're transplanting a large structural unit of both healthy cartilage and healthy underlying bone from a donor. We're essentially replacing the entire compromised osteochondral unit. It addresses the failing cartilage and the failing bone simultaneously. OAT autografts are usually too small to handle significant bony pathology, and ACI doesn't address the bone issue at all.
So OCA is the workhorse for bigger lesions with bony problems in revision.
It's the main tool, yes. It's the definitive revision procedure for most large cartilage defects that also have significant subchondral bone involvement.
And this structural solution is especially important in that tricky patellofemoral joint, isn't it?
Absolutely critical there. Probably the toughest challenge we face is managing kissing lesions in the PF joint.
Kissing lesions, meaning defects on both sides.
Exactly. Opposing cartilage defects on both the back of the patella and the trochlear groove it runs in. Trying to fix those with small plugs or just ACI is often doomed because of the high contact forces and complex 3D shape. Figure 33.8 shows a case using OCA for this.
So OCA is the answer for kissing lesions too.
OCA is often the best, sometimes the only answer. It allows us to transplant large anatomically matched bone and cartilage units to resurface both sides simultaneously, restoring that crucial complex PF articulation in a way that smaller grafts just can't.
Okay, one last tricky scenario. What about the patient who had an OCA before? It failed symptomatically, but when you look at the imaging, the graft itself looks, well, intact. It seems solidly in place, no major cracks or subsidence.
That's a frustrating situation. If a prior OCA is technically intact, looks well integrated, surface seems okay, no obvious structural failure, but the patient is still symptomatic, we typically do not rush in to revise the graft itself.
Why not, if they have pain?
Because the failure mechanism in that case is likely not the graft structure. It's probably due to something else we still haven't fully addressed. Maybe subtle residual instability, maybe chronic inflammation, synovitis, maybe persistent minor loading issues. Ripping out a well-integrated structural allograft is a major undertaking with significant bone loss. So the treatment for an intact but failed OCA is usually conservative management first, activity modification, injections, bracing, maybe a simple arthroscopic debridement to smooth any minor rough edges. But we generally avoid revising the main graft unless it's clearly falling apart.
Preserve the structure if possible. Got it.
Okay, we figured out the plan. Maybe it's a revision ACI, maybe an OCA, maybe with an osteotomy. Now comes the crucial conversation with the patient about what to expect. We must be brutally honest about the outcomes for revision surgery.
Because it's tougher the second time around.
Generally, yes. The data clearly shows that revision cartilage surgery is more complex, carries higher risks, and often has less predictable or slightly lower success rates compared to primary procedures. Let's start with outcomes following revision ACI.
We already hit on the big warning sign here, the prior microfracture.
We did, but it bears repeating because it's so significant. That data from Menas et al., Ref 17, showing a 26% failure rate for ACI done after a failed marrow stimulation compared to only 8% for primary ACI. That's a threefold increase in risk.
That's a conversation you absolutely have to have pre-op.
You have to. The patient needs to understand that the odds are somewhat stacked against the ACI working as well, simply because of the compromised biological bed we're starting with. Expectations need to be realistic.
But it's not all bad news for revision ACI, is it? There are successes.
No, absolutely not. There is successful data, too. For instance, revision ACI done for failed treatment of adult osteochondritis dissecans, OCB, has shown quite high success rates, around 85% according to Ref 3, and another study, Ref 23, reported an overall success rate of about 76% for revision ACI cases in carefully selected patients.
So it can work well.
It can, but I suspect that 76–85% success rate is almost entirely dependent on how well we did our detective work back in Part 3, and crucially, how thoroughly we addressed all the underlying mechanical issues, the alignment, the stability back in Part 4 before we implanted affected those new ACI cells.
If the knee environment is optimized, the biology has a much better chance.
Exactly. Get the mechanics right and the biology follows. Fail to fix the mechanics, and even the best biology will likely fail again.
Okay, what about the outcomes for revision OCA, the big structural allograft? How does that perform the second time around?
This is interesting. Grassatelli and colleagues, Ref 8, compared primary OCA versus revision OCA. They found that ultimately the functional scores and the graft survivorship rates were actually pretty similar between the two groups long term.
Oh, that sounds encouraging.
It does, but there was a big catch. Their revision OCA group had a significantly higher reoperation rate along the way. 44% needed more surgery, compared to only 24% in the primary OCA group.
Double the reoperation rate. What does that mean?
It implies that while the final outcome might be okay, getting there is often a much bumpier road for revision OCA patients. The surgery itself is likely more technically demanding, and they're more prone to complications afterwards. Maybe issues with graft healing, non-union, maybe some graft subsidence or collapse, maybe persistent pain requiring minor procedures like hardware removal or a cleanup scope. More bumps in the road to get to the finish line.
And is the long-term durability as good for revision OCA?
That's where some concerns arise. Another study by Horton et al., Ref 11, looked specifically at revision OCA outcomes. They reported a concerning 39% overall failure rate, which translates to only 61% graft survival at 10 years.
Only 61% survival at 10 years.
Yes. That's significantly lower than what we typically expect for primary OCA survival. So while OCA is often our best or only option for fixing large bony defects in the revision setting, we have to be transparent with patients about that 61% 10-year survivorship number. It can be a very effective salvage procedure, but it carries a real defined risk of not lasting as long as a primary graft and potentially needing further intervention down the track.
So manage expectations carefully for both revision ACI and revision OCA.
Meticulously.
Okay, the surgery's done, the graft is in, maybe the osteotomy is done too. Now comes the final, absolutely critical piece, rehabilitation. This must be even more important after a complex revision, right?
Yeah. Rehabilitation is essentially the second phase of the surgical treatment. It's not optional, it's integral to success. And yes, after revisions, which often involve these complex combinations of procedures, graft, plus osteotomy, plus maybe a meniscus transplant, the rehab protocol has to be highly individualized, carefully progressed, and strictly adhered to by the patient.
What are the general principles? How do we start?
Generally, we start with a period of early protection. This almost always involves using a hinged knee brace to control motion and provide stability. And very importantly, aggressive use of a continuous passive motion CPM machine.
The CPM machine, the thing that bends the knee back and forth passively.
That's the one. We often prescribe it for 4 to 6 weeks post-op, sometimes for as much as 4 to 6 hours per day, broken into sessions.
Why is CPM so crucial, especially after cartilage surgery?
2 main reasons. First, cartilage is avascular. It has no direct blood supply. It gets its nutrition through diffusion from the joint fluid. The gentle, continuous motion provided by the CPM helps circulate that joint fluid, bathing the graft in nutrients, which theoretically aids healing and integration. Second, early motion helps prevent the formation of scar tissue and adhesions within the joint, maintaining range of motion.
Okay, brace and CPM for early protection. Now, the big one, weight bearing. This must vary a lot depending on what was done.
Hugely variable, and this is where patient compliance is tested. If the revision cartilage procedure was on the femoral condyle or the tibial plateau, or if the surgery included a major osteotomy like an HTO or DFO.
Then it's protected weight bearing.
Yes, definitely protected, partial weight bearing, often for a significant period, maybe 6 weeks, maybe up to 12 weeks in some cases. They'll use crutches and often a specialized hinged unloader brace that's designed to actively shift pressure away from the repaired compartment.
What about revisions in the patellofemoral compartment?
It depends. If the PF revision, say a trochlear OCA, was done without a TTO, the patient might be allowed to bear weight as tolerated fairly early on. However, they'll typically need to keep their brace locked in full extension when walking for the first several weeks.
Why locked straight?
To prevent knee flexion during weight bearing, which would put high compressive forces across that healing PF graft, locking it straight keeps the patella unloaded.
But if they did have the TTO, the tibial tubercle osteotomy.
Then the TTO dictates the weight bearing. Performing a TTO means we've surgically cut and moved a piece of the tibia bone. That bone needs time to heal, just like any fracture. So if a TTO was part of the revision, protected weight bearing, usually non-weight bearing or touchdown weight bearing on crutches, is mandatory, typically for at least 6 weeks, to allow that osteotomy site to consolidate. You cannot risk disrupting the TTO fixation.
Okay, so weight bearing is complex and tailored. What are the other early rehab goals besides CPM and protected weight?
The primary early goals, regardless of the specific procedure, are focused on regaining range of motion gently within protected limits, ensuring good patellar mobility, doing patellar glides to prevent scarring down of the kneecap, and initiating very basic, non-stressful muscle activation, things like isometric quadriceps sets, hamstring sets, glute sets, and core strengthening exercises, keeping the muscles firing without loading the graft.
When do they actually start building strength and loading the knee more functionally?
True functional strengthening, usually starting with closed chain exercises like mini squats, leg presses, step-ups if allowed, typically begins gradually between 6 and 12 weeks post-op. But that's only if the surgeon is happy with the early healing progress based on clinical exam and sometimes imaging.
And return to more demanding activity. Running, jumping.
That's much further down the line. Progression towards muscular endurance training, maybe starting some gentle jogging or cycling, and eventually plyometrics, jumping exercises, usually doesn't happen until at least 3 months post-op, and often significantly later, maybe 6 to 9 months or even a year for full return to sport, depending on the complexity of the revision. The schedule has to be flexible and criterion-based. We only progress when we're confident the biological and structural healing is robust enough to handle the increased load, and we know everything takes longer to heal and mature in the revision setting. Patience is key. #tag outro.
Wow. Okay, this has been an incredibly detailed and I think really necessary deep dive into the complexities of managing failed cartilage surgery. It's clear that this isn't just a simple redo. The whole process is, it's almost astronomical in its demands, isn't it?
It really is.
You have to be part molecular biologist to understand the different graft types and their healing potential. Part biomechanical engineer to figure out the loads, the alignment, the stability issues, and part master diagnostician, that's surgical detective, to put all the clues together and pinpoint the true reason for the initial failure.
The synthesis of all those parts is absolutely the key takeaway. You have to integrate everything. Knowledge of the specific risk factors we talked about for each index procedure, BMI, age, lesion size, that critical history of prior microfracture, and combine that with a full system mechanical evaluation to find and fix the culprits, the malalignment, the instability, the meniscal loss that were likely driving the failure in the first place.
Absolutely. And if I had to pick the single most important step in this whole complex revision process, it sounds like it's fixing the patient's entire mechanical environment first.
Without a doubt.
You simply cannot expect a new graft, doesn't matter if it's living ACI cells or a big structural allograft, to survive and thrive long-term if you put it back into the same unstable, misaligned, or overloaded knee that killed the first one. You have to address the patient's weight, fix the alignment with osteotomy if needed, stabilize any ligament issues, deal with meniscal deficiency, before you even think about treating the specific cartilage lesion itself. Fix the foundation before rebuilding the house.
Couldn't have said it better myself. And that brings us full circle back to the patient sitting in front of us. Given everything we've discussed, the increased complexity, those high reoperation rates, like the 44% for revision OCA, the sometimes lower long-term success rates compared to primary surgery, we absolutely must conclude by stressing how vital adequate patient counseling is. Expectations have to be managed realistically, meticulously, right from that very first revision consult. Patients need to understand the longer recovery times, the potential bumps in the road, and the realistic chances of long-term success. We're embarking on a much more complex, less forgiving surgical journey together.
Absolutely essential. Okay, that brings us to our final provocative thought for today. We spent a lot of time emphasizing that fixing the mechanics, the offloading with HTO or TTO, ensuring stability is the absolute priority, the foundation for success. So here's the question. As our biological tools continue to get better and better, maybe we develop superior ACI scaffolds, better ways to grow cells, improved allograft preservation techniques. If we can get to a point where we truly achieve optimal mechanical alignment and perfect soft tissue stability first, every time, how much better can we realistically expect these next generation biological grafts to perform when they're finally placed into an environment that's truly quiet and perfectly balanced from a mechanical standpoint?
That's a fascinating question, isn't it? It forces us to fundamentally reconsider why primary repairs fail so often. Are we really seeing true biological failure in that 25% of primary cases? Or perhaps, are many of those failures actually just misdiagnosed or unaddressed mechanical failures that our current biological techniques simply can't overcome until the alignment and stability are made perfect?
So maybe it's not the seed, but the soil that's the main problem.
Precisely. If, say, 75% of what we currently call biological failure is actually mechanical failure in disguise, then maybe our primary research and clinical focus needs to shift even more heavily. Perhaps less emphasis on tweaking the cell biology, and even more on perfecting the alignment jigs, the instability repairs, the meniscal replacements. It really challenges where we should be putting our efforts. It's a fundamental question about the interplay between biology and biomechanics, and it really dictates the future direction of cartilage restoration.
A really powerful thought to chew on as we head back to the clinic and the operating room.
Thank you so much for sharing all that insight today, and thank you all for joining us for this deep dive.